And thank you very much for inviting me, Graham, and the committee. So I'm going to take a liberal view of the Pacific, include Australia and New Zealand in it. And so we're certainly up against it with rheumatic fever, where there's no primary prevention, there's no vaccine, there's no test for it. There's not a lot of interest from drug companies, unlike a lot of adult cardiology fields. There's minimal interest from specialists, and I dare say probably half those involved in Australia are in this room now. So what I'm going to talk about is secondary prophylaxis, because obviously that's the one treatment that works. It's been proven to work for many years, and what's happening in the wider Pacific. I'm not going to talk about the primary prophylaxis study in New Zealand, a very important study by Denny Lennon. It's still not published, it's been presented a few times. And I'm not going to talk about the guidelines, but I would like to emphasize the guidelines that Jonathan and Gavin and Warren and myself and others were involved with. I think these really, it's a superb body of work, and they are now, the abbreviated form is in the Medical Journal of Australia, the Australian guidelines and the New Zealand guidelines, which obviously basically very similar, just instead of saying Aborigine and Torres Strait, we're talking about Maori and Pacific Islanders. They're published in the New Zealand Medical Journal, but both of them are on the respective heart foundations, and there's a lot more detail in the heart foundations. And I think when you publish your publications and you talk and you champion in your local region, I think you should be championing the guidelines. And I'm going to finish up talking a bit about echo screening with rheumatic heart disease, which is the new kid on the block we've got to come to terms with. So this slide is just to try and give you a little bit of hope that there we were in the 1950s and 60s, and some estimates in some pockets of Maori populations were estimated over 1,000 of acute rheumatic fever per 100,000 per year in the 5 to 15-year-olds old group, and now we're certainly down to less than 80. And there is, it does look like the Pacific Islanders are at higher risk for acute rheumatic fever than Maori. We thought Maori was sort of falling to 50 or 60, but it's probably below 80. We don't have good data about the those Pacific Islanders living in New Zealand. We don't have good data for all the 21 countries in the Pacific Islands, but again, what data there is suggests it's very, very high. And in Australia, we heard this morning that these rates, which were, I usually say when I'm in safer parts of the world like New Zealand, that Australians, yes, they're the top at cricket and top at swimming, but they've also got the top in acute rheumatic fever rates. But you're doing the right thing to get off the top of the leaderboard. Now, another encouraging slide, I think, for you as you are working, working to get your prophylaxis started. Here's Wairau and Gisborne, so that's the East Cape of the North Island, very high Maori, and rural, I should say, Maori, not just urban, but rural population. And their recurrence rate was 58% in the 1960s and 70s. And just remember that the recurrence rate is your recurrences divided by your annual total ARF rate. IM penicillin is implemented by David Frankish. And this slide, cardiologists like to use these actuarial curves, they're called. And so it's secondary, it's benzathine penicillin every 28 days. So you start off here with 100% of your cohort, and we've got 51 on benzathine and 57 on oral. And it just happened that after 6 years, we've got only one recurrence in the IM penicillin and 35% recurrences in the oral. So it's really, we only use 21-day when there's non-compliance or there has been a recurrence on 28-day, and we basically say oral should not be offered. Obviously, sometimes they end up on oral, but and I think today again some very important information from New Zealand, that the Auckland register started in the 1980s by John Newman, and there was a 20% recurrence rate, but each analysis, the latest one was done a few years ago, and of the late 90s, and we're down to 5% recurrences. The program failure rate, so that's the people that have been put on the register, because obviously not everyone gets put on the register for various reasons, but the majority do, is only 1.4 per 100 patient years, and the penicillin failure rate, so some of these people couldn't be found, or they changed address or whatever, didn't get their penicillin, so that's part of the program failure rate. But the true penicillin failure rate, where the penicillin was given, and there were 2 cases in this, and that works out at 0.07 per 100 patient years. So that is very important data that shows that even though pharmacologically the penicillin, you can't measure it much into that 4th week, it works at 28 days. Because the Koreans felt that 21 days, and in the Cochrane meta-analysis, the 21 days does come out better than 28 days. This, as I said, was Heather Spinetto's review with Diana Lennon, who runs the program now. But it should be emphasised that this is an urban setting, and even though I'd encourage you to aim for those statistics, it is much harder in your populations who are rural-based rather than urban-based. But again, how it stacks up internationally, and some of those figures there are from the old UK, US data. But again, except for the small study, that Auckland data is very, very good. So Jonathan went over the pathway of rheumatic heart disease, and to emphasise that even though there are some theoretical treatments, that really it's the secondary prevention that is the key. So what about the other islands in the Pacific? So here's Samoa, idyllic tropical island with two main islands, where we've got 60,000, 110,000. And so this should be perfect for delivering prophylaxis, because you've got referral hospitals, you've got smaller units, you've got nursing units. And in fact, there was a very good champion, John Adams, a Samoan, who got the secondary prophylaxis going very well in the 1980s. And then they had a death. I've heard whether it was 1 or 2, but it was an anaphylactic death with benzol. And naturally enough, the nurse downed tools, said this is terrible, and the whole program disintegrated. And so their whole secondary prophylaxis fell apart. What about Vanuatu? Well, here we've got a geographical nightmare in comparison to Samoa. Moderately big population, 200,000, 80 inhabited islands. They've had a program from 2003. It only serves Port Vila. They've got 40 had surgery out of 110 on the register, so they're really just dealing with the very worst cases And then they have visiting teams, well-meaning teams, who come out, operate, and then leave, and then the interest comes and then goes again. So they're under-resourced locally, and so it's a very big problem there. But the Lone Ranger in Tonto came, and I think you've got some very important people in this room, and Jonathan really undersold what some of his work has been doing, or just didn't have time to talk about it. But the work that he has organised through the World Heart Federation is superb in the Pacific, because he's really got a lot of interest going, and Sarah and Sam, who I haven't got a picture of Sam, but by getting the workshops going and the sub-workshops in the countries, and then we've had 2 now echo workshops, and just about all the Pacific countries have been once or twice. And so appropriately, the how to get a register, either starting or improve it, was emphasised. How much data to collect, I think it's very important. We've certainly got too much data in our forms. And it gets passed down to the junior person on a hospital admission, and so the accuracy has to be checked, and then it's the further you get away from source. You've got to be very careful having too much data. You've got to think, what's it going to be really used for? All that data, is it going to be used just for audit, or is it going to be research? Obviously training, obviously getting a lot of people involved is important, as well as the key individual or champion. But sustainability is the key on the long term. So one of my points today is that that Samoa, an example, people have been there before, and there's going to be people after us. So we've got to have people, we've got to train new champions, we've got to keep knocking with the governments and the people who hold the purse strings, that the importance of rheumatic fever. And as has been shown already, especially in Australia is a very good example, but in the Pacific Islands, your RHD prevalence actually goes up. And so here's another initiative. Here's Prof. Satu Viliali, and this is a slide of his, and so some of his initiatives in Samoa, making it a government priority, and so forth. There was a New Zealand Aid health promotion went out in 2000, 2001, and then the WHF with Jonathan's work, and so there is new initiatives going on. An interesting country is Nauru, 21 square miles of it, and Guanu gave us a very interesting talk about how there's no computer because the power's only on for half the day, so a manual register is better than a computer register there. There's, even in small idyllic places, there are conflicts between health professionals, and she's got no one she doesn't rely on any of them for a diagnosis, so she gets on the WHF website. So again, a very high number of cases and surgery being done in this small island. What about in Tonga and the secondary prophylaxis there? Now we've heard this morning about Australia's rates have improved. Fiji is a very difficult area, I think, with a big population that's now gone from it used to be 750,000 10 years ago, but it's now over nearly 900,000. So there are big problems with secondary prophylaxis. I think probably from what's published and what's known about French Polynesia and Hawaii, again with just more resources, more money, their programs are pretty good. Back to you, and this slide just been modified this morning because we heard some new information, but again, so 1997, Northern Territory, 39% recurrences, and there was data in Jonathan's talk this morning that's down to 20% recurrences, so that is encouraging. Whereas the penicillin actual delivery rate, we didn't hear a figure about Northern Territories, but we heard that I know that the central rate is still